Today we will see about neuroophthalmology. Before that, we'll just revise the surgical procedure, enucleation, surgical techniques for enucleation, and we'll see the surgical technique. First one is separation of conjunctiva and Tenon's capsule. That is the first condition. Then in that, conjunctiva is inside all around, and the limbus with the help of spring scissors and undermining of the conjunctiva and Tenon's capsule is done combinedly all around up the equator using blunt tipped curved scissors. The maneuver exposes extraocular muscles. This is the first procedure. The extraocular muscles are exposed. Separation of extraocular muscles. Extraocular muscle separation. The rectus muscles are pulled out one by one with help of muscle hook, and 3:0 silk suture is passed near the insertion of each muscle, and the muscle is then cut with help of tenotomy scissors, leaving behind a small stump carrying the suture. The inferior and superior oblique muscles are hooked out and cut near the globe. Cutting of the optic nerve. The eyeball is prolapsed out by stretching and pushing down the eye speculum. Eyeball is pulled out with help of sutures passed through the muscle stumps. Enucleation scissor is then introduced along the medial wall of the posterior aspect of the eyeball. Optic nerve is filled and then cut with scissors while maintaining a constant pull on the eyeball. Then fourth procedure is removal of eyeball. The eyeball is pulled out of the orbit by incising the remaining tissue adherent to it, and hemostasis is achieved by packing the orbital cavity with a wet pack and pressing it back. Inserting an orbital implant, preferably an orbital implant of appropriate size, should be inserted into the orbit and sutured with the rectus muscle. Closure of conjunctiva and Tenon's capsule done by separately. Tenon's capsule is sutured horizontally with 6:0 vicryl and chromatic catgut. Conjunctiva is sutured vertically so that conjunctival fornices are retained deep with 6:0 silk sutures, which are removed after 8 to 10 days after completion of surgery. Antibiotic ointment is applied. Lids are closed and dressing is done with firm pressure using sterile eye pads and a bandage. Fitting of artificial prosthetic eye. Conformer may use post-operatively so that conjunctival fornices are retained deep. A proper size prosthetic eye can be inserted for good cosmetic appearance. This one. Then we saw already. We'll move on to neuroophthalmology. The components of visual pathway starting from retina consists of optic nerve, optic chiasma, optic tracts, lateral geniculate, optic radiation, visual cortex. Optic nerve. Each optic nerve starts from optic disc, extends up to optic chiasma, where the two nerves meet. It is backward continuation of nerve fiber layer of retina, which consists of axons originating from ganglion cells. It also consists afferent fibers of pupillary reflex. Morphologically and embryologically, optic nerve is compared to sensory tract. Unlike peripheral nerves, it is not covered by neurolemma. The fibers of optic nerve, numbering about a million, are very fine in diameter as compared to 20 micrometer of sensory nerves. Like other parts of CNS, the optic nerve is also covered by meningeal sheaths. There are four parts of optic nerve: intraocular, intraorbital, intracanalicular, and intracranial. Intraocular starts from optic disc, pierces the choroid and sclera, converting into a sieve-like structure in the lamina crepullosa at the back of the eyeball. It becomes continuous with the intraorbital part. Intraorbital part extends from back of the eyeball to optic foramina. This part is slightly sinus to give play for eye movements. Posteriorly near the optic foramina, it is closely surrounded by annulus of Gin and the origin of four rectus muscles. Some fibers of superior rectus muscles are adherent to its sheath here and accounts for painful ocular movements seen in retrobulbar neuritis. Finally, the nerve is separated from ocular muscle by orbital fat. Intracanalicular part is closely related to ophthalmic artery, which lies inferolateral to it and crosses obliquely over it as it enters the eyeball orbit to lie on its medial side. Sphenoid and posterior ethmoid sinus lie medial to it and are separated by a thin body lamina. This relation accounts for retrobulbar neuritis following infection of sinus. Intracranial part of the optic nerve lies above the cavernous sinus and converges with its fellow over the diaphragma cilia to form optic chiasma. Meninges with diameter, arachnoid and durometer covering the brain are continuous over the optic nerves. In the optic canal, the dura is firmly adherent with surrounding bone. The subarachnoid and subdural spaces around the optic nerve are also continuous with those of the brain. Optic chiasma, it is a flattened structure measuring 12 mm and 8 mm. It lies over the tuberculum and diaphragma cilia, and therefore presence of visual field defects in a patient with pituitary tumor indicates supraocular extension. Fibers originating from nasal curves of the retina decussate at chiasma. This is optic chiasma. The fibers decussate over there. Optic tracts. These are cylindrical bundles of nerve fiber running outwards and backwards from posterior lateral aspect of optic chiasma. Each optic tract consists of fibers from temporal half of retina of the same eye, nasal half of the opposite eye. Posteriorly, each optic tract ends in lateral geniculate body. Here, the pupillary reflex fibers pass on to pretectal nucleus in the midbrain through superior brachium. Some fibers terminate in the superior colliculus. Lateral geniculate bodies. These are whole structures situated at posterior termination of optic tract. Each geniculate body consists of 6 layers of neuron, grey matter, and alternating with white matter formed by optic fibers. The fibers of second order neurons coming via optic tracts relay in this third order neurons. Optic radiation. These extend from lateral geniculate body to visual cortex and consist of axons of third order neurons of visual pathway. Visual cortex. It is located on the middle aspect of occipital lobe, above and below the calcarine fissure. It is subdivided into viscosensory area that receives the fibers of radiation and the surrounding visco-psychic area, peristriate area 18 and parastriate area 19. Blood supply is mainly supplied by pile network of vessels except the orbital part of optic nerve, which is also supplied by an axial system derived from central artery of retina. The pile plexus around different parts of the visual its contribution from different arteries as shown in 13.2. The supply of the optic nerve head needs special mention. Surface layer of the optic disc is supplied by capillaries derived from retinal arterioles. Pre-laminar region is mainly supplied by centripetal branches of peripapillary choroid with some contribution from vessels of lamina corporosa. This is internal carotid artery, middle cerebral artery, deep optic artery, middle cerebral artery, radiation fibers, calcarine artery, posterior cerebral artery, anterior choroidal artery, basilar artery. Blood supply of optic nerve, central collateral artery, central retinal artery, short posterior ciliary artery, then pile plexus, dura, etc. Pathway of visual sensations versus somatic sensations. Lamina corpora supplied by branches from posterior ciliary arteries and arterial circle of Zinn. Retrolaminar part of optic nerve is supplied by centrifugal branches from central retinal artery and centrifugal branches from pile plexus formed by branches from choroidal artery, circle of Zinn, central retinal artery and ophthalmic artery. Pathway of visual sensations versus somatic sensations given in figure 13.4. Pathway of visual sensations. It arises from sensory end organ, retina, then posterior root ganglion, which is this, and nucleus gracilis, then thalamus, and then cortex, and versus somatic sensations from ganglion cell. From cone ganglion cells, it moves to chiasma, lateral genital body, and cortex. Pathway of visual sensation versus somatic sensation. Pathway of somatic as well as visual sensation consists of 3 neurons. Corresponding parts of pathway of these sensations are shown in 13. Somatic versus visual sensations. Features: sensory end organ, nerve endings in skin, visual sensation, rods and cones. Feature: neurons of first order lie in posterior root ganglion, lie in bipolar cell layer of retina. Neurons of second order lie in nucleus gracilis or cuneatus, lie in ganglion cells of retina. Neurons of third order lie in thalamus, lie in geniculate body. Lesions of visual pathway. Silent feature and important causes of lesions of visual pathway at different levels are given figure 13.5. Optic nerve lesions. Lesions of optic nerve salient features: marked loss of vision, complete blindness on affected side associated with abolition of direct late effects on ipsilateral side and consensual on the contralateral side. Near reflex is present. Common cause of optic nerve lesions are optic atrophy, traumatic avulsion of optic nerve, indirect optic neuropathy, ischemic optic neuropathy, acute optic neuritis, etc. Lesions through proximal part of optic nerve salient features are ipsilateral blindness, contralateral hemianopia, abolition of direct light reflex on affected side and consensual on the contralateral side. Near reflex is intact. Chiasmal lesions. Cause of chiasmal lesion. Intrinsic causes which produce thickening of chiasma itself include gliomas and multiple sclerosis. Extrinsic causes include comprehensive lesions include as pituitary adenoma, craniopharyngioma, meningioma. Other causes of chiasmal syndrome include metabolic, toxic, traumatic, and inflammatory conditions, lymphoid hypophysitis, sarcoidosis. Features of chiasmal lesions. Isomal Syndrome. Chiasma refers to set of signs and symptoms associated with lesions of optic chiasma. Anti-chiasmal syndrome produced by lesions that affect the ipsilateral optic nerve fibers and contralateral inferonasal fibers located in the Willebrand knee, typically producing the so-called junctional scotoma. Combination of central scotoma in one eye and temporal hemianopia defect in other eye. This one, central scotoma and hemianopia. This is anterior chiasmal syndrome. Middle chiasmal syndrome, it is produced by lesions involving decusating fibers in the body of chiasma, typically producing bitemporal hemianopia and bitemporal hemianopia, paralysis of pupillary reflex. Rarely the middle lesions can affect the uncrossed temporal fibers and produce nasal or binasal hemianopia. Posterior chiasmal syndrome is produced by lesions affecting caudal fibers in chiasma. Characteristic features are paracentral bitemporal field defects occur because macular fibers which cross more posteriorly in chiasma damage in posterior chiasmal lesions. Visual acuity and color vision may be preserved as temporal macular fibers are not damaged. Homonymous hemianopias on the contralateral side may occur when posterior chiasmal lesions involve the optic tract. Lateral chiasmal lesions. Salient features of such lesions are binasal hemianopia associated with binasal hemianopia, paralysis of pupillary reflex. These usually lead to partial descending optic atrophy. Common causes of such lesions are distension of third ventricle causing pressure on each side of chiasma, atheromocarotids or posterior communicating arteries. Heterochiasmal lesions. Heterochiasmal lesions include lesions of optic tract, lateral genicular nucleus, optic radiations, occipital lobe. Contralateral homonymous hemianopia of different forms such as incomplete, congruous or incongruous or complete depending upon the site of lesion is predominant field defect of all heterochiasmal lesions. Lesions of optic tract. Causes of optic tract lesion include intrinsic lesion include demyelinating disease and infection. Such lesion produce optic tract syndrome type 2. Extrinsic compression lesions include pituitary adenoma, craniopharyngioma, tumors of optic thalamus and large aneurysm of superior cerebral or posterior cerebral arteries. Other causes include syphilitic meningitis, gamma and tubercular meningitis. Characteristic features include incongruous homonymous hemianopia, asymmetrical field defect involving either height of visual field of both eye. Right homonymous hemianopia in left optic lesions or left halves of visual fields of both eyes. Left homonymous hemianopia due to lesions of right optic tract. This is explained anatomically by fact that each optic tract contains fibers from ipsilateral temporal half of retina and contralateral nasal half of retina. Contralateral hemianopia pupillary response, that is Wernicke reaction. Optic distension. Optic tract lesions produce descending type of partial optic atrophy characterized by temporal pallor on the side of lesion, bow tie atrophy on the contralateral side. Visual acuity is usually intact in the intrinsic lesion of optic tract. Ipsilateral third nerve palsy and ipsilateral hemiplegia may be associated with optic tract lesion in some cases. Lesions of lateral genicular nucleus are as below. Homonymous hemianopia produced is usually incongruous. Pupillary reflex are normal as fibers from pupillary reflex from the optic tract are diverted to pretectal nucleus and do not reach the LGN. Optic disc pallor may occur due to partial descending atrophy. Reasons of optic radiations. Combination of optic radiation include vascular occlusion, tumor, trauma, temporal lobotomy for seizures. Lesions for visual optic nerve, proximal part of optic nerve. This one is optic nerve proximal part of optic nerve, central chiasma, lateral chiasma, both sides. Then optic tract, and geniculate body. 6 is geniculate body. 7 is part of optic radiation and in temporal lobe. Part of radiation in temporal lobe. G is part of radiation in parietal lobe. Optic radiation. Then 9 is optic radiation. 10 is visual cortex sparing macula. 11 is visual cortex only macula. 12 is bilateral visual cortex only by macula. Visual device in the lesions of optic radiation vary depending upon the site of lesion as below. Superior quadratic hemianopia, pie in the sky, is produced when inferior fibers are involved in temporal lobe lesions. Anatomically, it is explained by the fact that inferior fibers of optic radiation contain fibers from ipsilateral lower temporal retina and contralateral lower nasal retina. Inferior most fibers of optic radiation from the so-called Mayer loop. Inferior quadratic hemianopia, pie on the floor, is produced by when superior fibers are involved in parietal lobe lesions. This is explained anatomically by the fact that superior fibers of optic radiation contain fibers from ipsilateral upper temporal retinal and contralateral upper nasal retina. Complete homonymous hemianopia is produced when total fibers of optic radiation are involved, sometimes with the sparing of macula. Pupil reflex are spared in lesions of optic radiation. Optic disc atrophy does not occur in lesions of optic radiation as second order neuron synapse in the lateral geniculate nucleus. Lesions of visual cortex. Characteristic features of visual cortex lesions can be described as visual field defects and other manifestation. Visual field defects in occipital lobe lesions include congruous homonymous hemianopia is a feature of occlusion of posterior cerebral artery supplying the anterior part of visual cortex. Congruous homonymous macular defects include current lesions of tip of occipital cortex following head injury or gunshot injury. Bilateral homonymous hemianopia with macula sparing producing a picture of ring scotoma is seen in bilateral occipital lobe lesions. Bilateral homonymous macular defects presenting like bilateral central scotoma. Cortical blindness can occur in bilateral occipital lobe lesion. Dyschromatopsia, acquired color blindness. Visual hallucination occurring in occipital lobe lesions are unformed, while in temporal lobe lesion the visual hallucination are formed. Palinopsia, that is persistent or recurrent perception of visual image, may occur. Visual anesthesia, transposition of visual stimuli from one hemifield to another. Polyopsia, multiple images of single objects in occipital lobe lesion does not disappear on closing of eye. Pupil reflex, light reflex. When light is shown in one eye, both pupils consequence of pupils to which light is shown is called direct light reflex, and that of other pupils is consensual indirect light reflex. Light reflex is initiated by rods and cones. Pathway of light reflex. This is ciliary ganglion. From ciliary ganglion, third nerve, then optic, which then enters the central gray matter, aqueduct and lateral geniculate body. Heading a visual nucleus is present here. Pretectal nucleus and posterior commissure. Pathway of light reflex include afferent fibers extend from retina to pretectal nucleus in midbrain. These travel along the optic nerve to optic chiasma, where fibers from nasal retina decussate and travel along the opposite optic tract to terminate the contralateral pretectal nucleus, while the fibers from temporal retina remain uncrossed and travel along the optic tract of the same side to terminate the ipsilateral pretectal nucleus. Internuclear fibers connect each pretectal nucleus with the Edinger Westphal nucleus of both sides. This connection forms the basis of consensual light reflex. Efferent pathway consists of the parasympathetic fibers which arise from Edinger Westphal nucleus in midbrain and travel along the third cranial nerve. The preganglion fibers enter the inferior division of third nerve and via the nerve to the inferior oblique reach the ciliary ganglion to relay. Postganglion fibers travel along the short ciliary nerves to innervate the sphincter pupillary. Near reflex. Near reflex occurs in looking at a near object. It consists of two components: convergent reflex, that is contraction of pupil and convergence, and accommodation reflex, contraction of pupil associated with accommodation. This is the pathway of convergence. Um, Pathway of convergent reflex. Its afferent pathway is still not elucidated. Assume that the afferents from medial recti travel centrally via third nerve to mesencephalic nucleus of fifth nerve to presumptive convergence center in tectal or pretectal region. From this, the impulse is led to Edinger-Spall nucleus, and the subsequent efferent pathway of near reflex is along the third nerve. The efferent fibers lay in the accessory ganglion before reaching the sphincter pupilla. Pathway of accommodation reflex. The afferent impulses extend from the retina to parastriate cortex via the optic nerve, chiasma and optic tract, lateral genital body, optic radiation and striate cortex. From the parastriate cortex, the impulses are relayed to Edinger-Spall nucleus of both sides via the occipito-mesencephalic tract and pontine center. From the Edinger-Spall nucleus, the efferent impulse travel along third nerve and reach the sphincter pupilla and ciliary muscle after laying the accessory and ciliary ganglions. This one is pathway of near reflex. Convergent reflex, accommodation reflex, convergent reflex, medial rectus, third nerve, mesencephalic nucleus of fifth nerve, convergent center. Then accommodation reflex. Psychosensory reflex. It refers to dilation of pupil in response to sensory and psychic stimuli. It is very complex and its mechanism still not elucidated. Abnormality of pupillary reactions. Amaurotic light reflex. It refers to absence of direct light reflex on the affected side and the absence of consensual light reflex on the normal side. This indicates lesions of optic nerve or retina on the affected side, that is right eye, leading to complete blindness. In diffuse illumination, both pupils are of equal size. Efferent pathway defect. Absence of both direct and consensual light reflex on the affected side and presence of both direct and consensual Q light reflex on the normal side indicates efferent pathway defect. Near reflex is also absent on the affected side. Its causes include effect of parasympatholitic drugs, that is atropine, homotropine, internal ophthalmoplegia and third nerve paralysis. Wernicke hemianopic pupillae. It indicates lesion of optic tract. In this condition, light reflex, ipsilateral and contralateral consensual, is absent when light is thrown on temporal half of the retina of the affected side and nasal half of the opposite side, while it is present when light is thrown on the nasal half of affected side and temporal half of the opposite side. Marcus gun pupil, RAPD. Its paradoxical response of pupil to light in presence of relative afferent pathway defect and causes of Marcus gun pupil include incomplete optic nerve lesions and severe retinal disease. It is tested by swinging flashlight. Argyll Robinson people. Here both pupils are slightly small in size. Reaction to near reflex is present, but reflex is absent. Light reflex is absent, and there is light near dissociation. To remove the acronym ARB, both pupils are involved and dilate poorly with mydriatics. It is caused by lesion in the region of tectum. Aid is tonic pupil. In this condition, reaction to light is absent and to near reflex is very slow and tonic. The affected pupil is larger. It is caused by post-ganglionic parasympathetic pupilomotor damage. It is usually unilateral associated with absent knee jerk and occurs more often in young women. Aid's pupil constricts with weak pilocarpine drops, while normal pupil does not, because the denervated iris sphincter is supersensitive to topical parasympathomimetics. Anisocoria. Normal size of pupil varies between 3 to 4 mm depending upon the room illumination. Difference between size of two pupils is called anisocoria. Anisocoria may physiological or pathological. Physiological anisocoria is usually minimal. Both pupils react well to light and there is no dilation lag. Pathological anisocoria is usually a difference of 2 mm or more and may either be due to abnormal myosis or mydriasis of one pupil. Cause of myosis and cause of mydriasis we'll see feature. Evolution of anisocoria. Pupil size in dim and bright illumination should be noted first. Anisocoria same in dark and bright illumination is usually physiological. Anisocoria greater in dim light is suggestive of sympathetic palsy, and smaller pupil is normal. Physiological anisocoria also sometimes behave in this manner. Pupil light reflex should be tested after noting the pupil size. Poor light reaction indicates defect in parasympathetic system, and normal light reaction followed by dilation lag indicates Khurana syndrome. Pharmacology tests are conducted after noting the pupil light reaction. Pharmacology test for suspected parasympathetic palsy. People constrict to low concentration pilocarpine. People constrict to usual concentration pilocarpine. People does not constrict with pilocarpine. Mydriasis due to parasympathetic drugs. Other condition where dilated people does not constrict with pilocarpine or traumatic mydriasis. Pharmacology test for suspected sympathetic pulse. Cocaine test. Small people fails to dilate in Horner syndrome. Hydroxamphetamine test. Small people dilates in central or preganglionic, and preganglionic does not dilate in postganglionic Horner syndrome. Disease. Congenital anomalies, traumatic lesion, inflammatory lesion, vascular disturbance, degeneration, tumors, etc. Optic neurosis etiology. It includes inflammatory and demyelinating disorder of optic nerve. Etiology, idiopathy. In a large proportion of cases, the underlying causes unidentifiable. Hereditary optic neurosis and demyelinating disorder are by far most common cause of optic neurosis. These include multiple sclerosis, neuromyelitis optica, and diffuse periaxial encephalitis of Schilder. Para-infectious optic neurosis associated with various viral infections such as measles, mumps, chickenpox, whooping cough, glandular fever. It may also occur following immunization. Infectious optic neurosis may be sinus related or associated with cat scratch fever, syphilis during primary or secondary disease, tuberculosis, Lyme disease, meningitis in patients with AIDS. Autoimmune disorders associated with optic neurosis include sarcoidosis, systemic lupus, Parvatitis nodosa, Guillain-Barré Viginous disease. Clinical profile. Anatomical types: papillitis, neuroretinitis, retrobular neuritis. Fundus photography showing papillitis. Papillitis refers to involvement of optic disc in inflammatory and demyelinating disorder. These conditions usually unilateral but sometimes may be bilateral. Neuroretinitis refers to combined involvement of optic disc and surrounding retina in macular area. Retrobulbar nerve is characterized by involvement of optic nerve behind the eyeball. Clinical features of acute retrobulbar neuritis are essentially similar to that of acute papillitis except for fundus changes and ocular changes described below. Typical versus atypical optic neuritis. The term typical optic neuritis refers to one associated with demyelination, particularly multiple sclerosis, and term atypical neuritis is labeled for one associated with causes other than demyelinating disorder. Clinical feature: optic neuritis may be asymptomatic or may be associated with the following symptoms: visual loss, dark adaptation, visual obstruction, bright light as a typical symptom of acute optic neuritis. Visual loss, monocular, sudden, progressive, and profound visual loss is hallmark of acute optic neuritis. Impairment of color vision is always present in optic neuritis. Typically, the patient observes reduced vividness of saturated colors. Movement of phosphenes and sound-induced phosphenes may be received by patient with optic neuritis, and phosphenes refer to glowing sensation produced by non-photic or so-called inadequate stimuli. Episodic transient obscurance of vision on exertion and on exposure to heat, which occurs on resting or moving away from heat. Without symptom occur in patients with isolated optic neuritis. Depth perception, particularly for moving object may be impaired. Pulfrich phenomena. Pain. Patient may complain of mild dull eye ache. It is more marked in patients with retrobular neuritis than papillitis. Pain is usually aggravated by ocular movements, especially in upward or downward direction due to attachment of some fibers of superior to durameter. Signs are as follows: visual acuity is usually reduced markedly. Color vision is often severely impaired. Pupil shows ill sustained constriction to light. Marcus gun pupil, which indicates relative efferent pupillary defect, is a diagnostic sign, and it is detected by swinging flashlight test. Ophthalmoscopic vision. Pupil is corrected by hyperemia of disc, blurring of margin, disc become edematous. And physiology cup is obliterated. Retinal veins are congested and tortuous. Splinter hemorrhages and fine exudates may be seen on the disc. Slit lamp examination may reveal inflammatory cells in vitreous. Inflammatory signs may also be present in surrounding retina when papillitis is associated with macular star formation. And the condition is labeled neuroretinitis. In majority of cases with retrobulbar neuritis, fundus appears normal and condition is typically defined as disease where neither ophthalmologist nor patient sees anything. Occasionally temporal pallor of the disc may be seen. Visual field changes. The most common field defect in optic neuritis is a related central or centrocecal scotoma. Other field defects noted rarely include paracentral nerve fiber bundle defect or nerve fiber bundle defect extending up to periphery, and nerve fiber bundle defect involving fixation point and periphery. The field defects are more marked in red color than white. Contrast sensitivity is impaired. Visual evoked response shows reduced amplitude, delay in transmission time. Fundus fluorescein angiography reveals mild to moderate leak in early phase with increases with time. Differential diagnosis: papillitis should be differentiated from papilloedema, ischemic optic neuropathy, anterior orbital compressive neuropathy, and pseudopapilloedema. Acute retrobulbar neuritis, it must be differentiated from malingering, hysterical blindness, cortical blindness, and indirect optic neuropathy. Evolution recovery complication. Evolution in optic neuritis, typically the visual acuity color vision is not progressive over 2 to 5 days. Recovery, the rate of visual recovery is lower than the rate of visual loss and usually starts within 2 weeks and takes between 4 and 6 weeks. About 75 to 90% cases get good visual recovery. Complication: recurrent attacks of acute retinal neuritis are followed by primary optic atrophy, and recurrent attack of diabetes are followed by post-neurotic optic atrophy leading to complete blindness. Treatment of the causes: effort should be made to find out and treat the underlying causes. There is no effective treatment for idiopathic hereditary optic neuritis and that associated with degenerative disorders. Radiosteroid therapy may be shorten the period of visual loss but will not influence the ultimate level of visual recovery.